Hi, this is Mrs. Griffin, and today we're going to talk about comfort and pain management. Pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain has a complex story. Today we know pain assessment as the fifth vital sign, but in the mid-1990s, the American Pain Society pushed aggressively to promote pain medications. We know and understand that pain control is a measure of satisfaction, and it's linked to reimbursement. Pain is subjective. So as nurses, a priority responsibility is to assess your client's pain level and provide individual interventions. What is pain? Well, pain is one of the most common reasons people seek medical care in the U.S. The pain experience can significantly interfere with a person's quality of life, nearly affecting every aspect. For example, back pain can affect a client's job performance, engagement in social activities, sexual intimacy, sleep, rest, the ability to exercise, and perform ADLs. Pain can cause sleep loss, irritability, cognitive impairment, functional impairment, and immobility, which can all be destructive to the patient and the family. Take a look at this classification of pain chart. We're going to break it down. So by origin, superficial pain, that arises from the subcutaneous tissues. It's touching a hot object or a paper cut. This is short-term pain. Then we have deep somatic. This originates from ligaments, tendons, nerves, blood vessels, and bones. More localized and can be described as achy or tender. So think a fracture or a sprain or even bone cancer. Visceral, this is caused by deep stimulation of deep internal pain receptors, most often experienced in the abdominal cavity, the cranium, or the thorax. It's not well localized, and it can be described as tight, pressure, cramping. So I think of menstrual cramps, labor pain, GI infections, bowel disorders, and organ cancers. Radiating pain, this pain starts at the origin but extends to other locations. So think a sore throat may extend to the ears and the head. Think GERD may radiate outwards and involve the entire upper thorax. Referred pain, and you can see the picture here, occurs in an area that is distant from the original site. So pain from a heart attack may be experienced down the left arm or in the back or jaw. Phantom pain, it's perceived to originate from an area that has been surgically removed. And then we have psychogenic pain. This is believed to arise from the mind. The patient perceives the pain despite no physical cause can be identified. So moving to the next, by the cause. We have nociceptive pain, which occurs when pain receptors, called nociceptors, respond. So think of thermal, so heat or cold. Mechanical, a finger caught in a door or breaking a skin, or chemical, that can be your mucous membranes. And then neuropathic pain. This is complex. It's often chronic pain that arises with injury to one or more nerves, and it's constantly repeated transmission of pain signals, even in the absence of painful stimuli. So nerve injury can be from conditions such as poorly controlled diabetes, stroke, tumor, alcoholism, or viral infections such as shingles or HIV. Next, we have by duration. So acute pain, that's short in duration, rapid onset. It can last up to 6 months, per the American Pain Society, and usually associated with an injury or surgery. Chronic pain lasts longer than 6 months and often interferes with daily activities. And along with chronic pain, we also need to think about depression that comes along with it, anger, frustrations, and dependence that comes with that. Intractable pain is both chronic and highly resistant to relief. This should be approached with multiple methods of pain relief. And we're going to talk about description of pain a little bit later in this PowerPoint. So question. It is most important for the nurse to understand the various ways in which pain is classified so they can take a moment and think about this. You can pause this video. However, the correct answer is C. The correctest answer is C. So think about different modalities are used in the treatment and management of pain and are often based on how the pain is classified. So we want to make sure as nurses, as RNs, that we develop that effective pain management plan. Let's break down assessing pain. So we're going to start with location. Ask your patient, where is your pain? Does it radiate anywhere else? And ask the client to use the one finger point method so they can put it exactly where they're having pain. Quality. How does the pain feel? Is it sharp? Is it dull? Is it burning, stabbing, pounding, throbbing, shooting? Is it heavy, tight? Get what they're saying. How does it feel? And measuring. There's multiple pain scales. We're most familiar with the number scale, 1 to 10 scale, as you can see here on the slide, with 0 being no pain and 10 being the worst pain you've ever had in your life. Underneath that numeric pain scale, you'll see here, we have the Wong-Baker Faces scale. This needs to be used with children that are 3 years and older. There's also for infants, the face, legs, activity, cry, and consolability pain scale, and you'll learn more about that in 201. Next, we're moving on to timing. What is the onset, duration, frequency? Ask your client, when did it start? How long does it last? How often does it occur? Is it constant or intermittent? The setting. How does the pain affect your daily life or your ADLs? Ask where you are when the symptoms occur, and does the pain affect their sleep or ability to work? Associated manifestations. Be sure to document fatigue, depression, nausea, anxiety. You want to ask your client what other symptoms that they're feeling when they're having pain. And aggravating and relieving factors. Ask the client, what makes the pain better? What makes it worse? And are they taking any prescriptions or over-the-counter medications? Factors affecting pain response. We could talk about this subject for hours, but let's think about some of the major things. Age, developmental stage, social and cultural influence, a client's emotional status, past experiences with pain, the meaning to them associated with pain, the lack of knowledge about their pain, lifestyle habits, and patient limitations. When I think of patient limitations, I think of their language. Is there a language barrier? Do they have hearing loss? Do they have a lack of understanding? Do they have fears of addiction or side effects? And also sensory and cognitive impairment. Responses to pain. So number one, we have the autonomic nervous system. You guys will learn more about this in Mod 3. But we have the sympathetic and the parasympathetic nervous systems. That sympathetic nervous system activates the fight or flight response. And the parasympathetic nervous system restores the body to calm. So think about what's going on. You can see this little visual chart here. The sympathetic nervous system is increasing our blood pressure, increasing our heart rate, dilating our pupils. It may trigger some fear, anxiety, aggression, where the parasympathetic nervous system is responsible for the rest, repair, and healing. So it's counteracting and lowering that heart rate and promoting recovery. We also know that certain behaviors are directly related to a pain response. And activity of daily living. How is your client affected? Body reactions to pain. Let's start with our endocrine system. Ongoing pain triggers excessive release of hormones. Cortisol, antidiuretic hormone, catecholamine, glucagon. We know that these hormone shifts, especially with our insulin, activate carbohydrate, protein, and fat breakdown, which equal hyperglycemia and poor glucose control. Cardiovascular, unrelieved pain leads to hypercoagulation. So that means increased clotting. And an increased heart rate, blood pressure, cardiac workload, and oxygen demand. Increased cardiac workload, along with hypercoagulation, may lead to unstable angina. As far as our muscle skeleton, it's obvious if our patient is not doing well in physical therapy and is not doing well with their activities of daily living because of impaired muscle function, fatigue, and immobility. Respiratory. Your client in pain tends to breathe shallow and limits that thoracic abdominal movement. This is called involuntary splinting. It reduces the tidal volume. So the tidal volume is air exchanged with each breath. So think of the volume of air that you're breathing in. In the normal adult, that's about 500 mLs. Women are just maybe a little less. As far as your urinary system, pain can cause the release of excessive amounts of catecholamines, aldosterone, ADH, cortisol, angiotensin II, and prostaglandins. These hormones decrease urinary output, which can cause urinary retention, which lead to fluid overload, hyperkalemia, and hypertension. And finally, the GI system. We know that intestinal secretions and smooth muscle tone can increase, and then gastric emptying and motility decrease. Circling back around to the respiratory, think about these changes with your tidal volume can lead to pneumonia and atelectasis, and hypercarbia, which is retained carbon dioxide, and respiratory acidosis. As nurses, we use many non-pharmacological treatments to help assist our patients with managing their pain. Proper positioning is number one. There may be aromatherapy, distraction, imagery, and you can see other things listed here on the slide as far as TENS, PENS. Surgeons may implant a spinal stimulator, acupuncture, acupressure, massage, and use of heat and cold. You can find all of these in detail in your Fundamentals ATI book under pain management. Okay, pharmacological pain management. So non-opioids, we have our NSAIDs, non-steroidal anti-inflammatory drugs. This includes aspirin, ibuprofen. They act on the peripheral tissues by interfering with the production of prostaglandins. So prostaglandins sensitize pain receptors that are involved with inflammation. No more than 2,400 milligrams a day. Be sure your clients are taking these medications with food or milk to decrease GI irritation. And be careful if your client has impaired or compromised kidney function. There is, of course, an increased risk for bleeding. We do not give aspirin to children because it causes Reye's syndrome, so that's liver and brain swelling. Acetaminophen has very little anti-inflammatory effect, but it does have analgesic and fever-reducing properties. There are fewer side effects with acetaminophen. They rarely cause GI problems. Now, one thing we do have to think about is Tylenol toxicity. So Tylenol or acetaminophen is contained in over 100 products. So think about Percocet, think about Dayquil. We want to make sure we're doing good client teaching, no more than 4,000 milligrams a day of acetaminophen. There are 4 stages of acetaminophen toxicity. Stage 1 is those preclinical toxic effects. So that's our nausea, vomiting, abdominal pain. Their labs may still be normal. Stage 2, liver injury develops. Usually your client's experiencing some right upper quadrant pain. Your LFTs and INR are going to rise at this point. Stage 3, that is when you become hepatotoxic. That's when you're having liver failure, hypoglycemia, and encephalopathy, coma, even death. So there is an antidote to an acetaminophen overdose. It needs to be given 8 to 10 hours. This is your acetylcysteine. In stage 4, that is recovery for those that survive stage 3. We also talk about adjuvants. So this reduces the amount of opioids that a patient requires. These drugs in this category include anticonvulsants, antidepressants, topical agents, muscle relaxants, and corticosteroids. And then, of course, we have our opioids. They can be natural or synthetic compounds to relieve pain. They vary in potency, and they work on finding the pain receptors to bind with and block the pain impulse. Opioid receptors include mu, delta, kappa, and sigma. So here on this slide, you're going to notice this PCA pump. That's patient-controlled analgesia. Your client, it's a 2-nurse check. Your client can have a basal rate and or a bolus. You'll also notice the spinal catheter at the bottom here for an epidural. And in closing, let's discuss. Here's a little mini case study. You are assessing an older adult experiencing intense acute pain related to hip fracture. Her health record indicates documented abuse of prescription narcotics. 1 hour after receiving an opioid dose, she is moaning loudly in pain while rattling the bed rails. She repeatedly calls you for more pain reliever, even though you have already administered analgesics as prescribed. What might you assume about what is going on with this situation? Drop I'd love to know your thoughts, so drop some thoughts and comments in the discussion on D2L. Thanks, and if you have any questions, feel free to let me know.